will all match.
All right, it's 7:05.
Okay. Just give me the signal.
Okay, I think we'll get started with the event. So thanks everyone for joining us. Dr. Zane Cohen is on the call tonight, the director of our center, and is going to give us a welcome. Go ahead, Zane.
Well, yes, I'll use the word welcome. This is an unusual presentation, a virtual presentation, and it's the third Familial Polyposis education night for families and individuals with FAP and MAP. It's taken quite a bit of organization, and I want to start really by thanking our genetic counselors, Kara Samodia, who's taken the lead for this evening, Melissa Aronson, and Tom Ward. We really have a great group of genetic counselors, and I want to publicly thank them. We're expecting tonight over 100 people who are to log in, and I think in speaking to the audience, you are going to be educated, and I hope you will learn a lot from the speakers that we have for this evening. I'm going to turn it over to Kara now to introduce the topics and the speakers and a few housekeeping rules, and I will be back to you at the end. So Kara, take it away.
Right. Thank you, Dr. Cohen, for that warm welcome, and thank you all for joining us this evening. I'm Kara Samodiak, one of the genetic counselors at the Zane Cohen Center, as Zane mentioned. Before we get started formally with our first speaker of the evening, I wanted to go over a few details about how things will be running tonight. It's our first time doing this event online, obviously, rather than in person. And while we missed the personal aspect of getting together and mingling in person, we also found that the Zoom was able to accommodate people from far and wide that aren't necessarily in Toronto. So that's a plus. There are pros and cons, certainly, but thank you for joining us. And I also wanted to introduce our other two genetic counselors who you can see on the screen here, Melissa Aronson and Tom Ward, if you want to give a wave, and Hardin Wang, our IT specialist who's helped put a lot of this together as well. Tom and Melissa might look familiar to you as your genetic counselors for your families, but they'll be helping out tonight with doing some introductions and monitoring of questions as well. So thank you in advance for that. Tom has permanently joined our team as of 2018, replacing Laura Winter, who didn't end up returning after her maternity leave. So Tom has taken over all of Laura's families, as some of you may have already spoken to him or met him. But if Laura was your genetic counselor, you could contact Tom with any questions going forward. So formal welcome to Tom stepping in for Laura. And as well, another staffing change on the horizon is that Spring Holter, who may be the genetic counselor for some of you, is transitioning over to work more in the area of pancreatic cancer. So if your family was followed by Spring in the past, your care will be transitioned over to one of Tom or Melissa or myself. And so just to let you know that in advance. So if you do have any questions or you need assistance, you can contact our main line and we'll assign you to another genetic counselor. And otherwise, just in terms of housekeeping, this is the webinar version of Zoom. So it's a slightly different format than the Zoom that you might have been using at home with your friends and family or for work meetings. So in this version, the attendees won't be seen or heard. So your microphones and cameras aren't activated, but the speakers only will be seen and heard. But we will still have a question period. It's just that in this format, if you see at the bottom of your screen, there's a Q&A section. So if you click on that button, you can type a question during any of the talks. And Tom and Melissa and I will monitor those questions, consolidate them, and then relay them to the speaker at the end of each talk throughout the evening. And hopefully we can get to as many questions as possible. We may not be able to answer them all, but if there are some common questions or themes of questions that we can't get to, perhaps we can ask the speakers later offline and post some answers to questions on our website if there are a lot that we don't get to. So bear with us, but we will try to accommodate as many of you as we can. And if we can just try to keep in mind to keep the questions more general and applicable to a larger audience rather than personal medical questions, as the speakers won't be able to answer any personal questions about your own care. I think that's everything for now. And as I said before, the videos will be posted later on our website. So without further ado, I would like to introduce our first speaker of the evening. We have Diane Miles-Reed, you can see on the screen. And Diane, she graduated from the genetic counseling program at Sarah Lawrence College and has been employed for many years as a genetic counselor at Mount Sinai as well, but in a different department. So Diane's in the prenatal diagnosis and medical genetics department, and as well more recently in the Mount Sinai fertility program. In addition to prenatal diagnosis, Diane's interests include reproductive genetics and education. Diane enjoys the collaboration between prenatal diagnosis and Mount Sinai fertility, and specifically providing counseling to patients and couples interested in pre-implantation genetic testing for various genetic conditions. Diane is actively involved in teaching as well as a clinical supervisor, lecturer, and course coordinator for the University of Toronto's genetic counseling program. So please help me in welcoming Diane, who will be speaking about pre-implantation genetic testing in familial polyposis. So Diane, I'll turn it over to you.
Thank you. Thanks, Kara, for that lovely introduction. It's my pleasure to join you tonight, and I'm just going to set up my slides here. It's my pleasure to join you tonight and share some information about the option of pre-implantation genetic testing. So hopefully for those of you who are aware about this option or know a little bit about this option, I can provide you with some additional details and information. And for those who are not aware about the option of pre-implantation testing, hoping to introduce this as an option you might consider. So what is pre-implantation genetic testing? We call it PGT for short. So we often will just use the letters PGT. It's a little bit shorter, not so much of a mouthful. So this PGT is an assessment of an embryo for a known genetic variant. So a genetic, we used to say the word mutation, but genetic change or variant can also be used to test for chromosomal differences in an embryo prior to transfer. And really the goal of genetic testing of embryos is to identify embryos that are at low risk, either for chromosomal differences or genetic conditions. With the goal to have a child who is healthy. So PGTM specifically is referring to pre-implantation genetic testing for monogenic or single gene conditions. And we say PGTM for short, and I've put in brackets, we used to call this PGD. And so in some documents or literature, you might still see PGD, which stands for pre-implantation genetic diagnosis. And really is just indicating that we're looking for something very specific. So with PGTM, we're testing for the known familial gene variants. And so if we think about testing for polyposis, we would be testing for those very specific genetic variants that have been identified in an individual or in a family. So with PGTM, we can test for autosomal recessive conditions. Those are conditions where both members of the reproductive couple are carriers for a condition and therefore have a risk to have a child affected. We can test for autosomal dominant conditions. So thinking about polyposis, that's the FAP. Other examples of autosomal dominant conditions would be BRCA1 or 2, Marfan syndrome, many different conditions. And with autosomal dominant conditions, as you're probably aware, these are conditions where one individual in the couple usually is affected with the condition and then has that 50% chance to pass on the genetic variant to any offspring. We can also test for X-linked conditions. We can't talk about PGTM without talking about PGTA, so I will touch on that a little bit tonight, although it won't be the focus of our talk. PGTA, and also known as PGS, is screening for aneuploidy. So these are changes at the chromosome level. So when we're thinking about PGT-M and testing for familial variants, that's at the gene level, single gene testing. But we know that a certain percentage of embryos are chromosomally abnormal, and this will impact the embryo's ability to implant and lead to a successful ongoing pregnancy. And so testing at the chromosome level with PGT-A generally goes hand in hand with PGT-M testing. So we'll touch a little bit about that tonight as well. So I have to share this slide, which many of you may have seen before if you've met with a genetic counselor, or we'll go back to high school biology for just a minute, just to remind you that our genetic information is packaged into our chromosomes. And so, of course, our DNA is making up our genes, and then our genes, those hundreds and thousands of genes are packaged into the chromosome. So each chromosome really is made up of hundreds or thousands of genes. All of the chromosomes, as you know, are found in each of the cells of our body. Okay. So I'm going to use this slide just to give an overview of PGT-M. PGT-M, it is very specific. And so an interesting point with PGT-M is that you actually do need to meet with a genetics team specializing in pre-implantation testing for a review of the genetic testing that's been completed in yourself or in your family members. And they need to work with you to build a test that will test your embryos. And that usually involves collecting DNA samples from the reproductive couple, usually from both members of the couple. And then the PGT lab, so this is a special reference lab that the fertility clinics will work with. The PGT lab is going to design a test that's very unique for each family. And of course, we then need to go through the IVF cycle. And so anyone who wants to test their embryos will have to have IVF to create those embryos. And so I'll explain IVF in brief. It really means that the female partner would need to be taking medications, hormone injections, to stimulate the ovaries to produce more follicles in a given cycle. The follicles are then retrieved from the ovaries at the appropriate time in the cycle, and then egg and sperm would be put together in the lab for fertilization to occur. So once fertilization occurs, the fertilized eggs will be grown in culture in the lab for 5 or 6 days before the embryo will become a blastocyst. And so in this image, you can see to the bottom right, you can see an embryo biopsy, it says, and that's showing a picture of a blastocyst biopsy at 5 or 6 days after fertilization. A few cells are removed from each of the embryos that continues to develop at blastocyst stage. And those cells are sent to the reference PGD lab that made your test. The cells would be sent to the lab for testing for the specific genetic variants. Meanwhile, all of the embryos that were biopsied for testing would be frozen at the fertility clinic as results are completed. So once results are received, those results would be communicated back to the couple, and then the information is provided as to whether the embryos have inherited the genetic changes in question, whether they are predicted to be affected with the genetic condition in the family, or on the other hand, is the embryo predicted to be unaffected and therefore good to transfer back into the uterus. And so when there are embryos that are suitable for transfer, then of course the couple will work with the fertility doctor to plan the embryo transfer. I'm just showing you this image to show you that blastocyst, the embryo at day 5 after fertilization. And you can see that to the left of the embryo, there's this sort of clump of cells. We call that the inner cell mass. And these cells will continue to develop to make up the fetus and then the baby. So as this embryo implants in the lining of the uterus, the cells continue to replicate and divide, and the inner cell mass will become the fetus. On the outer layer of this embryo, we see what's called the trophectoderm layer. These cells in the trophectoderm layer will develop to become the placenta. And it's these cells that are biopsied from the embryo. It's a fine balance when we're testing embryos because we don't want to cause harm or damage to the embryo. And that means that the embryology staff can only remove a few cells from each of the embryo. I'm showing you an image here of a trophectoderm embryo biopsy. So you can see here that they are removing, it's almost like pulling out a few cells from that trophectoderm layer of the embryo. And usually the goal is to remove between 5 and 10 cells from the trophectoderm. So this embryo at day 5 is made up of 1 to 200 cells in general. And generally, it's felt to be safe to take out a handful of cells for genetic testing. Okay, so if you were interested in pre-implantation testing, what would that look like? What's the process? Well, first you would have to be referred to a fertility clinic. And a referral can be initiated from your genetic counselor, from your genetics clinic, or from a family doctor. It's important that whoever does initiate a referral to the fertility clinic includes genetic testing results and some sort of documentation of the genetic condition within the family, who's been tested, and what specifically those genetic results have shown. Once in the fertility clinic, you'd be meeting with a fertility doctor. The fertility doctor is going to, of course, take all of the information that's being provided, but go one step further to determine, are there any issues with fertility? That would involve investigations for both reproductive partners, can involve blood tests, sometimes ultrasounds, semen analysis. So lots of investigations really just to make sure that the fertility treatments are appropriate for that couple, and also to sort of guide the process to know what medications to prescribe as part of the IVF cycle. You would also be meeting with a genetic counselor specializing in the pre-implantation testing to provide you with that information about the logistics, the timing, the costs, the statistics, what's the chance that you will have embryos that are suitable to transfer. Of course, your genetic counselor will sort of outline the option of PGT-M and PGT-A and put you in touch with the reference PGT lab. A referral would be initiated to the PGT lab if the decision is to move forward. And as I mentioned briefly earlier, the PGT lab is really going to prepare a test for testing your embryos. So we call it a probe. So this is a test that's specific to the family, specific to the couple, and would require samples, again, from each of the reproductive partners, really to determine that they can provide an informative test for each of your embryos. The lab wants to make sure that they can identify the same genetic variant that's been identified in the affected individual or in the family, to know that they can identify that genetic change in the embryo DNA. And also they go one step further and use a technique so that they're looking at additional markers around the gene in question to really have a very specific test for each couple's embryos. The test development takes about 2 to 3 months. So it's important to sort of have in your mind that the process of PGT-M does take some time to get ready for the IVF cycle even. You know, when you're referred to a fertility clinic, of course, there's a wait for an appointment. And then once you get to the clinic, there's lots of appointments that need to happen before, in fact, you are working with the PGT lab. And then even at that point, there's still a couple of months in order to build that test. Then would come, once the test is ready for the embryos, then of course, you would be going through an IVF cycle. As I mentioned with the IVF cycle, that's where the female partner would be taking hormone injections to stimulate the ovaries to produce more follicles. Fertilization is occurring in the lab. Embryos are grown for biopsy. Once the embryos are biopsied, as I mentioned earlier, they would be frozen and we would be waiting for those results. The PGT results generally take about 2 to 3 weeks for PGT-M. And then once we get those results, results are communicated, of course, to the couple as well as to the fertility team, and then plans underway to proceed with an embryo transfer. And really an embryo transfer means that, again, the woman would be taking some medication to prepare her body, the lining of the uterus, to receive that embryo. So it'd be very much timed within the menstrual cycle. What are the benefits of PGT-M? Well, clearly, for many families, the most important benefit is that there is a potential to identify embryos that are unaffected with the genetic condition in the family, and can really lower the chance to have a child affected with that specific condition. Another benefit of PGT-M is that it's highly accurate. It's about 98% accurate. Many couples have a goal when they're doing IVF with PGT-M that perhaps with one IVF cycle, they may be successful to create enough embryos that they have more than one embryo that is unaffected with the genetic condition in their family. This doesn't always happen. I guess, you know, one of the unknowns with IVF is that we never know how many embryos will be created in a given cycle, but certainly that can happen. It does happen. And so sometimes with one IVF cycle, you can produce, again, more than one unaffected embryo. And for some couples, it allows them to have children who are unaffected with the condition in their family without having to perhaps have prenatal testing and make difficult decisions during a pregnancy. Some couples have voiced that, you know, they may do prenatal testing, but they would really want to avoid having an affected child if possible, and may even consider stopping a pregnancy. Certainly, IVF with PGT-M provides an alternative, and for many couples, this alternative is something that's perhaps easier for them to proceed with. I'm going to switch gears a little bit and talk about chromosomes. And really, if you recall, our chromosomes come in pairs. And so we have 23 pairs of chromosomes, or 46 chromosomes in every cell of our body. That's the usual number. So on the left-hand side, you can see the normal chromosome number, 2 copies of each pair. On the right-hand side, you're seeing an image where there's an extra copy of chromosome 10. And this is an example of what we call chromosomal aneuploidy, where there's an extra copy of a chromosome within the cells. And when we think about aneuploidy, this is something that usually starts when the egg and the sperm come together. The reason that I bring this up is that when we are testing embryos, it's not uncommon that we find embryos that are chromosomally abnormal or aneuploid. And this is important information to have because, in fact, embryos that have the normal chromosome number, those embryos, we call them euploid, those embryos have the highest chance of leading to a successful implantation and ongoing pregnancy. Whereas an embryo that has an extra or missing chromosome, or a large part of a chromosome that's missing or extra, those embryos really have a much lower chance of implantation, and on the other hand can be associated with a high chance of miscarriage. And so generally couples who are doing PGT-M testing specific for the gene variant in their family, they often will choose to test their embryos at the chromosome level as well with PGT-A testing. To give you just a sense of how common chromosomal aneuploidy is, in IVF cycles, at least 40 to 60% of embryos are chromosomally abnormal, and this number can be up to about 80% in women over the age of 40. So what we know is that chromosomal aneuploidy in general increases with maternal age. And so I guess when we think about even women who are less than 35, for example, or probably still have about 30 to 40% of their embryos that may be chromosomally abnormal. And then as we get into the mid 35, you know, it's almost 50% chance would be chromosomally abnormal. So just to give you that statistic, this is why we do talk about PGTA with couples doing IVF. PGTA can really help to identify embryos that are chromosomally normal or euploid for transfer. And this, as I mentioned, it increases the chance of success with that embryo transfer. Okay, so what are the limitations of PGT? PGT is highly accurate, but it's not 100% accurate. There are limitations. Certainly some of these limitations stem from the fact that as part of the biopsy, the embryologist can only take a few cells, taking between 5 and 10 cells generally. And this is a limitation in itself. Sometimes those cells are not intact, or they don't have the DNA material present in the middle of the cell. Sometimes the DNA quality from those embryo cells is poor, and that may mean that the PGT lab cannot provide an informative result. Sometimes the DNA quality is poor if the embryo quality is poor. And so that can certainly happen in the IVF clinic. I guess it's important to remember that everything we're doing in the lab. And so there are many, many contributing factors, and not all embryos are good quality, and not all embryos have good quality DNA. And so sometimes this can be lead to difficulties in the analysis, or difficulties having an accurate result. It's also important to remember that we're taking cells from the trophectoderm, so that is a limitation as well. We cannot take cells from the inner cell mass, from that part of the embryo that will actually become the fetus and then the baby. So we're hoping and assuming that the DNA within the trophectoderm cells is the same as the DNA within the inner cell mass, but it's sometimes in a small percentage of cases there may be differences between the cells of the embryo. So it's highly accurate, not 100% accurate. It's also important to keep in mind that the genetic testing that we are doing on the embryo is very specific. So very specific to the genetic condition within the family. We are not testing for all genetic conditions. We're not testing, even though we're looking closely at the chromosomal DNA, we're still not able to screen for all genetic conditions. We're not testing for, learning disabilities, or, I'm asked a lot, are you testing for autism? We can't rule out birth defects. In fact, there's lots of things that we cannot test for. So the testing is actually very specific and limited in scope. I think when we also must point out that there's no guarantee. And so there's no guarantee that we will have a result for each embryo, or an informative result. So probably 2 to 3% of embryos, unfortunately, have either no DNA, no amplification of DNA, or an inconclusive result. So it's important that we make couples aware of that before going ahead with this process. It doesn't happen often, but when it does happen, it can be very frustrating and disappointing, and we understand that. It is possible that you could go through an IVF cycle with PGT and not have any embryos that are suitable for transfer. Unfortunately, sometimes it does happen that all of the embryos are affected and have inherited the genetic change in the family, or sometimes chromosomally abnormal, or sometimes embryos that are unaffected with the genetic condition. If you're testing for FAP, for example, sometimes those embryos that are not affected with FAP, maybe they are chromosomally abnormal. And so sometimes that happens. I guess what we know again is that as women get older, in general, there's a higher chance for chromosomal aneuploidy. And so, as a woman gets older, probably lower chances to find those embryos that are suitable for transfer. in that case, then there's no embryos, or sorry, I guess in some situations, there's no embryos to biopsy. That's another possibility. Again, it doesn't happen often, but sometimes as you go through the IVF cycle, you know, there's not fertilization, or perhaps the embryo stopped developing before the embryo biopsy would occur. So that can be very disappointing too. It's also important to note that sometimes the embryo transfer is not successful. So certainly not all embryos that are transferred back into the uterus will result in a pregnancy. On average, we know that if the embryo has been tested with PGT-A and is chromosomally normal, then the chance of a successful implantation and pregnancy is about 55 to 65% chance. So again, not 100% chance. So there's lots of limitations, but again, coming back to the fact that, you know, I think PGT it's a good test, it's a solid test, and it is highly accurate, but just important to know that there are these limitations. What are the costs? So this is also important. So PGT-M costs about $5,000 to $6,000 just for the PGT-M. PGT-A is less costly. It's usually a fee per embryo. At Mount Sinai Fertility, the clinics, the PGT labs that we're working with charge anywhere between $300 to $500 per embryo for PGT-A. And then one big fee that accounts for part of the cost for PGT testing is the biopsy fee. So the fee that you're paying to the fertility clinic staff to biopsy those embryos. And that's about $2,500 per cycle at Mount Sinai Fertility. I can't speak to costs at other clinics, but I'm guessing it would be somewhat comparable. And so just taking everything into account, it's about $10,000 for PGT per IVF cycle. So each time you're doing a stimulation cycle and creating embryos and doing PGT-M, it costs about $10,000 altogether for the PGT piece. The IVF fees are also expensive and will vary clinic by clinic. With the cost of the IVF, that includes the actual process itself, the process of putting egg and sperm together for fertilization. On top of that, that cost is about $10,000, I would say, for IVF ICSI. And I think, again, sometimes a little bit lower, sometimes a bit higher than that, depending on which clinic you're working with. Additionally, there would be fees for the medications, the hormone injections that are taken to stimulate the ovaries to produce more follicles. This does vary also depending on the medication and the dose, and is estimated to be anywhere sort of between $3,000 and $7,000 per cycle. Oftentimes, if individuals have benefits packages, this is usually what's covered, is the medication. There's also fees to transfer the embryos back into the uterus. A transfer cycle can be about $3,000. And then there are fees to store the embryos. And so just as a rough ballpark figure, it's about $10,000 to $15,000 per IVF cycle. I'll inform you about the Ontario Fertility Program, which you might have heard about. And so the Ontario government a few years back decided that each couple was entitled to one funded IVF cycle as part of the Ontario Fertility Program. And so what does that fee include? That fee includes that fee to cover IVF, the IVF process. And that's about $10,000. The Ontario Fertility Program funding does not cover the PGT costs, and it also doesn't cover the medications that a woman would need to take as part of that IVF cycle. So it does cover the Ontario Fertility Program it's a nice chunk of change, if you will. It does cover a big portion of an IVF cycle, but still there are additional fees, including PGT. Okay, how do you decide if this is right for you? There's lots of things to think about. the potential benefits and limitations. We've talked a lot about them. Timing. It's important to know that with PGT, it does take time. It doesn't happen, you know, in a couple of weeks. It actually takes several months. And for couples who are thinking to do PGTM, keep in mind that there is that 3 months that's needed to make a test for testing the embryos. So it's several months before you would actually go ahead with the IVF cycle. And then once you're doing the IVF, again, waiting for results and then timing a transfer after that. So it's important to keep in mind that it does take some time. There's the emotional component. I mean, I think that many couples feel that PGT allows them to have confidence in the fact that they're working towards having, you know, a child that's unaffected with an inherited condition. You know, maybe for them, it seems more reasonable to proceed with PGT rather than conceiving naturally and doing testing in a pregnancy. I think as a female going through IVF, sometimes there can be physical, you know, challenges. It's not always easy with the hormone injections, and sometimes it leads to sort of, you know, emotions and moods, and it can be uncomfortable to do the retrieval of the egg. So there's some considerations there too. I just want to point out that an alternative to pre-implantation testing is prenatal diagnosis, and there are tests available to test in a pregnancy. And, you know, if we're comparing and contrasting with prenatal testing, all of the costs to test a pregnancy are covered by OHIP. So, you know, I think for couples who really cannot afford PGT, or, you know, are not successful with one cycle, perhaps sometimes couples are not successful with one cycle but cannot afford a second cycle, prenatal diagnosis is another option. And for some couples, I think it's sometimes easier to conceive naturally. And so sometimes it's the emotional component, I guess, of what to do with information. If one is conceiving naturally, would they test a pregnancy? What would they do with that information? That's where for some couples, the option of PGT seems like a more reasonable approach, I guess, sometimes. But just have to warn that PGT can sometimes have its own challenges. So it's sometimes having to weigh out all of the pros and cons. Okay, I think that's the end of my slides at this point.
Thanks, Diane. That was really informative. And we have a few questions coming in, and a few that we were interested in ourselves as well. So firstly, I wanted to ask you, if someone finds out that they have FAP, so for some of our patients who might not be in a relationship or have a partner or be thinking of having kids at the time when they find out that they have FAP, if they're not, you know, in a couple, and they want to consider freezing eggs and having testing later on, and how does that work? Mm-hmm.
That's an option as well. And so that would be sort of the similar process in that you would want a referral to a fertility clinic. And then we do have, you know, specialists at the clinic who can talk about that option with you. I think in general, I think, you know, it has been very successful for some individuals who, as you point out, don't have a partner as of yet, but do want to freeze their eggs, you know, and sort of optimize age in a way if they are worried about their age, or for some individuals, they want to preserve their fertility. So sometimes it's a matter of freezing their eggs before having certain medical treatments that might impact their fertility. That can be a benefit for sure.
Okay, thank you for that. And also just logistically, if someone was interested in getting a referral to your clinic, what's the best timing for that? Can they come and get information right after perhaps finding out about a diagnosis of FAP, or is it better to wait until being in the family planning stage, or what's the best timing for someone to consider?
That's a great question. I think one could come for information for sure, and have a consult both with the fertility specialist as well as genetic counselors to provide information about PGT options for sure. That might even just help with family planning to know some of the information, I guess. As women particularly are getting older, everything becomes a little bit more challenging in the fertility clinic, and that information may actually, provide information such that couples may choose to start their family planning perhaps a little bit sooner, even to optimize their chances.
Definitely good to think about. And if someone does want a referral, how do they go about getting that? They need a referral, I imagine. And
yeah, so can get a referral either from their family doctor or genetic counselors. I think it would be important to have the genetic testing information, those results passed on with the records to the fertility clinic. That would be important. But yeah, referral can come from either family doctor or a genetics clinic.
Great.
Mm-hmm. I didn't put the website, but there is, of course, Mount Sinai Fertility has a website. All of the information would be on the site with regards to forms for referral and the processes. Yeah.
Great.
Hi, Diane.
Tom, you had a question?
Another question. Yes. Is PGT a standard offering at most fertility clinics, or will some of our patients who maybe live further afield from Toronto, would they likely have to come to a specialized center to be offered PGT?
Good question. I think it's not offered at all fertility clinics. I think most of the sort of clinics in the downtown GTA area are offering PGT, although still there are many clinics that don't have, they don't really have the technology or the skill set to biopsy embryos. So that's sort of a limiting factor for some of the clinics. Sometimes you can do some of your investigations or, closer to home, and then just come down to the downtown clinics for PGT and for the actual IVF cycle, sort of in the cycle, if you will. And so some couples who live from afar or, don't have a clinic near them that's doing PGTA, they would work with their doctor and figure out timing and maybe come down and stay downtown for a few days that when it's needed as part of their cycle, and then have to maybe come back for embryo transfers as well. But yeah, I don't think all clinics are offering this option. That's a good question.
Thank you.
Great. Thank you. I think that's all the questions that we have. So thank you, Diane, for joining us tonight and for that really informative talk. I know it'll be very useful information for a lot of our families. So thanks very much.
Great. Thank you. My pleasure.
Great.
Okay, I now want to introduce Dr. Ava Gupta, who will be speaking to us about managing desmoid tumors and familial polyposis. Dr. Gupta is a staff oncologist at both the Hospital for Sick Children and Princess Margaret Hospital. Her primary clinical and research interests include sarcoma, adolescent and young adult oncology, and desmoid tumors. She is the medical director of the Adolescent and Young Adult Oncology Program at Princess Margaret, and is also the founding medical director of the Canadian Sarcoma Research and Clinical Collaboration, and is interested in clinical trials for sarcoma and desmoid tumors. Thank you so much for being with us today, Dr. Gupta.
Thank you for having me, and thank you to everyone who's here participating in tonight's event. So I will just share my screen. Okay, and I wanted this to be more of a discussion rather than a formal presentation, so please feel free to jump in and ask questions anytime. So I think one of the hardest things about having a desmoid tumor that, first of all, requires treatment is that people with desmoid tumors who are referred for management are actually referred to a cancer center. And so, in fact, what happens is that they are referred to a cancer center, seen by a cancer doctor, and have to have imaging just as people with cancer do. But yet people with desmoid do not have cancer. And we know that this is actually a great burden, emotional burden actually, that all of our patients with desmoid face. So I just wanted to acknowledge that. And I wish that wasn't the case and that we could move our entire desmoid practice outside of the cancer center. So I just wanted to highlight a few different points today, but please welcome any other questions on any other topics that might not be immediately covered here. So the first is, what is a desmoid? Second, we can talk about most common clinical presentations. Third, we can talk about various treatment options. The fourth theme that I wanted to spend some time about is to treat or not to treat, which is actually one of the most important and upcoming, you could say, debates in the treatment of desmoid. How we follow people who have desmoids, and then we can just summarize main points. So the first thing is, what is a desmoid? So a desmoid is actually caused by a mutation in one of two genes. In people with FAP, the gene that has a mutation in it, as you all know, is called APC. In those individuals who do not have FAP, they have a mutation in a gene called beta-catenin. But the end result of either a mutation in beta-catenin or in the APC gene both result in the formation of a desmoid. And is essentially what happens is that the mutations within these two genes cause stability of a very specific protein, and that is what is responsible for the formation of a desmoid. So this is why people with FAP are at risk for desmoid tumors. I want to emphasize this over and over again. Desmoid tumors are benign. They are never cancer and will never become cancer. The term benign suggests that this tumor, although it's called a tumor, does not have the ability to spread to other places in the body. If something has the ability to spread to other places in the body, that is what we call malignant or cancer. However, just because something is benign does not mean that it's not problematic. And we all know that, or maybe you know of people who have desmoids that are problematic. But a desmoid will never, ever be cancer. This is probably the best way to think about a desmoid. Think of sticky peanut butter. Desmoids are highly infiltrative tumors. They think of desmoids as not just a solitary, well-defined lump, but this mesh of tumor that has fronds and tentacles or is sticky like peanut butter. And this is why often when a surgeon tries to resect a desmoid, often there is probably little pieces of desmoid that are left behind that the surgeon cannot see, almost like little specks of peanut butter that might be left on the bread. And so whether the desmoid is in the abdomen or outside of the abdomen, I think this is a good way of actually thinking about desmoid. Locally infiltrative, but yet doesn't spread to other places in the body. So based on this, we can understand then what are the most common presentations of people with desmoid. So the most common presentation is actually an incidental finding. And that means that you would have a scan for some other reason, either follow-up of your colectomy or some other reason to have a scan. And by chance, the report of that scan, whether it's CT scan or MRI, would say there is a mass located in the mesentery of the small bowel or a mass in the pelvis, etc. And this is what we call an incidental finding. And even in individuals with FAP, desmoids are still probably the most common presentation is incidental. The second most common presentation is that of either abdominal pain and or bowel obstruction. So often people will have intermittent discomfort in their abdomen, pain, bloating after they eat, or have actual difficulties with blockage or obstruction of their bowel. And obviously those signs and symptoms would then lead to obtaining imaging or CT scan or MRI scan and show us the desmoid. And then the third common presentation, even in people with FAP, are desmoids that are not in the abdomen or not in the belly. And it's much more common for people without FAP to have desmoids in their arms and legs or back, or the wall of their abdomen or the abdominal wall, rather than inside the abdomen. But even people with FAP can get desmoids outside the belly. And in that situation, the desmoid can either cause, again, be a painless lump and people have no pain, or can be associated with pain. So in the past, the most common type of treatment that was offered for people with desmoid tumors was in fact surgical resection. Upfront surgery has now completely fallen out of favor for people with desmoid. And the reason for this, again, is if you picture that peanut butter sandwich, because in over 50% of situations, even if a patient undergoes surgery, and even if the surgeon has removed all of the desmoid, in more than half of situations, the desmoid is likely to recur. And so therefore, nowadays, much more common is medical therapy. And I've listed here two most common types of treatment options, medical treatment options. One is low dose chemotherapy. And the word chemotherapy for sure sounds uninviting, absolutely, especially when I've already told you that desmoids are not cancer. But the doses of treatment or of chemotherapy that we implement are really low dose. And the goal here is, again, to actually burn out or treat the desmoid. Here, the most common, every institution actually uses kind of different recipes, but the most common recipe of low-dose chemotherapy that we use at our hospital and in most hospitals actually in Canada are two drugs called methotrexate and vinorelbine. And these drugs are given intravenously and given for a prolonged period of time. Weekly chemotherapy that we give for almost 2 years. And the reason for such a prolonged exposure is really to ensure that this benign, often slow-growing tumor has an opportunity to be killed with this slow exposure of low-dose chemotherapy. In fact, there are no short-term or long-term side effects. There are no long-term side effects of chemotherapy. Some people, about 1 in 10 people, do have difficulties with nausea, most certainly, but the most negative aspect of low-dose chemotherapy is the fact that it's really intravenous and requires people to come back to hospital on a regular basis. The second, most common treatment for desmoid tumor is an oral drug called Nexavar. Another name for Nexavar is sorafenib. And this is a drug that is actually relatively new. A clinical trial was just published on Nexavar a few years ago. It's great because it's a pill, and you just take a pill once a day, and it's so much more convenient than getting intravenous therapy and having to come back and forth to the hospital. Some of the tricky things about Nexavar, though, is that it does have a side effect of having being associated with high blood pressure, and invariably, probably almost, I would say, almost 50% or half of the people who get Nexavar will require another medication to help lower their blood pressure. The other interesting thing about Nexavar is we actually don't know how long people need to stay on Nexavar for in order to cure their desmoid. It's just that that particular study or trial has not been ever performed, and nor will it be, I should add. with low-dose chemotherapy, we have enough experience now over decades to say that, usually people need 2 years of treatment, and with 2 years of treatment, we have over 90% chance that the desmoid will be cured and not recur. But with Nexavar, we just don't know what that number is. Do people need to be on Nexavar for 1 year, 18 months, 2 years in order to maximize the chance of not having a recurrence? That remains unknown. The third and definitely probably most important treatment option in desmoid is observation. And I will actually come to talk more about this at the next slide. So this idea of to treat or not to treat, as I mentioned, has become a very, very critical and emergent theme in desmoid. There are 3 different factors that we should all consider when trying to make a decision about whether or not someone requires treatment for their desmoid. So imagine, for example, you have a scan done for some other reason and the report says you have a desmoid. You are being followed by your FAP doctor or your gastroenterologist, and the question is, do you need referral for your desmoid? And if so, should we, and we see you in our clinic, the question is, do you actually need treatment for your desmoid? So that is a group decision made between us, the clinicians, and you as the patients. And the factors that we would consider in that decision making include, obviously, if somebody has symptoms from their desmoid. So if anybody has pain from their desmoid, or has ever had any problem with obstruction from their desmoid, then for sure, 100% we would suggest treatment. The second factor to consider are the imaging characteristics. So for example, if you have had serial or sequential imaging and it shows that the desmoid is growing, then especially in someone who has underlying FAP, probably we would recommend treatment of that growing desmoid. I would say this is maybe one aspect of desmoid treatment that's different in individuals with FAP compared to without FAP. In somebody who has a desmoid but does not have FAP, we call that sporadic desmoid, and there is very little risk to waiting to treat. You can, if someone does not want treatment for their sporadic desmoid, especially if it's in their arm or their leg and it's not causing any symptoms, no rush to treat at all, because this will never become cancer, as I mentioned. And if that individual has no pain, then there's really no rush to treat. In individuals with FAP-associated desmoid, especially if the desmoid is within their abdomen, then we are definitely more conservative in making that decision. And maybe even if there are no symptoms, but there is some evidence of growth of the desmoid, maybe we would advocate for treatment. And then thirdly, but most importantly, is really patient preference in terms of whether or not someone would like treatment for their desmoid. Some people prefer, in the absence of symptoms, is to really have a watchful and wait approach and just observation. Some people prefer just to get the treatment for their desmoid underway. So regardless of whether or not you decide to have treatment for your desmoid, the question is, well, how should we follow the desmoid? There's 2 main considerations here, and this time there's only 2 factors to consider, I suppose. The first is the type of imaging modality. There are 2 choices, essentially. We always want cross-sectional imaging, and the choices include CT scan versus MRI. Both are great imaging modality techniques. Both give us also great detail of the desmoid. And there's pros and cons to both. And I'm sure anybody on this call who's had either CT or MR could probably speak to the pros and cons of both scans. CT scans are associated with minimal, but are associated with small exposure to radiation. And so, especially for someone who's very young, who will, for example, need sequential CT scans very frequently for the rest of their lives, it's something, something to consider. But a CT scan is very quick. It takes 5 minutes to get a CT scan. Yes, you have to drink oral contrast, but it's very quick table time. In contrast, MRI scans, no radiation exposure, but you have to lie on that table pretty still for at least 45 minutes. And for anyone who has even mild claustrophobia, this can be quite difficult. And even if you don't have claustrophobia, to lie still for 45 minutes can be a challenge. So the bottom line, though, is both imaging modalities are great and will give us fantastic information about the desmoid. The other thing that's of interest also is with MRI scans, sometimes, again, if you think about that peanut butter, it's not a well demarcated and well circumscribed lesion. And so sometimes measuring these desmoids is very tricky. And so the other thing we look for on MRI scan is a change in what's in a very specific sequence of MRI called T2. And sometimes this change in the signal of the MRI, and sometimes even on the CT scan, can actually be quite helpful in helping to indicate treatment response. And so there may not be a change in the size of the actual desmoid, but a change in the quality or the way these desmoids actually look on the scan itself. The second item to consider in terms of follow-up is the frequency of scans. And I would say, depending on who your doctor is or which clinic you go to, there could be tremendous variability in this as well. My feeling in frequency of scans is less is more. And, so if somebody is on treatment, maybe at the beginning, we would offer scans, for example, once every 3 to 4 months. But as soon as we are confident that treatment is working, then we can space those scans out to every 6 months. In someone who's undergoing observation only, then either scans once a year or scans dictated by change in symptoms are definitely sufficient. So all of these things just require conversations between yourself and your treating physician. I will say that one of the most difficult aspects of having to undergo surveillance is the worry. And when people have cancer, we call this fear of cancer recurrence, but in individuals with desmoid, it's the same idea where there's fear of either desmoid progression or fear of desmoid recurrence. And sometimes that interval of waiting between scans can be quite stressful. And sometimes people feel fine between their scans, but then only feel some distress or anxiety when the night before their scan and then waiting for the results. And so I just wanted to also acknowledge that if you are feeling distress or anxious about having to wait for scan results or that those times in between your scans, please do bring that up with your physician, because I think it's definitely worth a conversation. I think it's very, very stressful for people to have to keep getting regular scans no matter what. As mentioned, my actual slides are very short, but I really just wanted to make this an open dialogue. And but really, the idea here is that desmoids are benign, but in individuals with FAP, it is definitely, desmoids are worthy of treatment consideration, probably above and beyond those who do not have FAP, and definitely talk to your doctor if you have a desmoid and you have any other questions. But perhaps now I can open the floor up for any discussion from the audience. Thank you for your attention.
Thank you so much, Dr. Gupta. We have a few questions that have come in for you. First of all, someone wants to know if someone with FAP doesn't initially present with a desmoid, do we know what their risk is later in life to develop one?
So the old teaching is that the development of an intra-abdominal desmoid is possibly triggered by the surgery required for a colectomy. But we also know now, with the passage of time, that just because somebody has a colectomy does not always mean that that person will develop a desmoid. In general, however, when large population studies have been done, the estimate is around that over a lifetime, about 1/3 of individuals with FAP will develop a desmoid, but we do not have actually good data or accurate information to tell you how many of those individuals actually need treatment for their desmoid. So probably 1/3 will develop one, but maybe some people will always have their desmoid undetected or detected, but not requiring treatment.
Thank you. And are there any risk factors that can point us to determine if someone might be at a higher risk to develop a desmoid?
Oh, I wish we knew the answer to that, in fact, because then it would actually give us a way to almost screen people for who would be more likely to develop a desmoid than others. We've seen desmoid in the context of, I mean, most people obviously that we see with FAP have already had their prophylactic colectomy done. And so everyone has that, I guess, in common. There are a few people actually who present with desmoid, and that's actually how their FAP is discovered. So they have not yet had their colectomy. So we can't even say that colectomy in and of itself is the only risk factor. So we have the biggest risk factor for developing a desmoid is the underlying FAP compared to any other. There's no other bigger risk factor than actually having FAP itself.
Thank you. And I have another question here. Is tamoxifen still a treatment option for desmoids?
Oh, that's a good one. So, when that's kind of asking someone, what's their favorite beverage, because every oncologist has their favorite cocktail or treatment combination that they prefer. So when I first started in practice, actually, I did use tamoxifen, not infrequently. The trouble in women is that if a woman takes tamoxifen and she's young, premenopausal, she will invariably go into menopause. And this can be quite difficult because women will have hot flashes, vaginal dryness, sexual dysfunction, etc. It's like really feeling like you're in menopause. So it's not very comfortable. And secondly, a woman can actually also sometimes have ovarian cysts that develop, which can be uncomfortable and painful. But for men, no problem. A man can take tamoxifen. A man will not grow breasts, and it's a very safe drug to give in a man. However, but I know that across the country, many of my colleagues actually do continue to use tamoxifen. And when I've spoken with those women or those female patients, they've actually reported, they felt fine on the tamoxifen. So in my own individual practice, I must admit that I have not used it very frequently lately, but I do know that many of my other oncology colleagues across the country still do use tamoxifen. So I think it's a great option because it's oral, and especially if somebody has either minimally symptomatic, desmoid, and they are not interested in IV chemotherapy or anything more intense. I think it's still a reasonable thing to consider.
I think we have time for one last question, and that's if someone is not known to have a desmoid, should they consider imaging or screening to determine whether they have a desmoid or not? And if that's recommended, how should they go about doing that?
Oh, yeah, I wish Dr. Glady was here for this question. So Dr. Glady is one of the sarcoma surgeons that I work with at Mount Sinai Hospital, whom many of you may know. So she was part of an international working group that had sarcoma doctors or desmoid doctors from across the world of all different disciplines. And in fact, there is no international consensus guideline for how individuals with FAP should be screened, or if individuals with FAP should be screened for desmoids, number one, and secondly, if so, how should they be screened, like with ultrasound or MRI, for example. So at the moment, there's definitely no indication for asymptomatic screening for desmoid in people with FAP. And the primary reason for that is because if you think about my slide about to treat or not to treat, if you have no symptoms that you have any abdominal discomfort, abdominal pain, then we probably would advise no treatment anyways. So I was actually, when I was asked to give this talk, I think I really do want to emphasize that I don't want to increase anyone's anxiety about worrying whether or not they have a desmoid, especially if you feel well. I hope you continue to feel well even after this talk. But if you do have persistent abdominal discomfort, abdominal pain, then I think it's pretty simple to ask your doctor for a scan, and we'll be happy to see you.
Thank you so much. I know we have quite a few other questions, but I don't know if we have time for it tonight, but hopefully we can, get some of your answers to you later. Thank you so much, Dr. Gupta.
For sure. You can please just you can email me or contact me through the DTRF through Desmoid Canada, actually, and I'll be happy to take more questions, or we can set up another evening like this. Thank you so much, everyone. Take care.
Thank you.
Thank you so much, Dr. Gupta. Someone actually commented that the Desmoid Tumor Research Foundation is a really good resource, and the Canadian Desmoid support groups. So there are some support groups, and we're really grateful to Dr. Gupta for talking about that. So I'm going to be introducing our next speaker, who's Dr. Rob Greif. I've known Dr. Greif since I began working, so we've both been there for a long time. And he's a colorectal surgical oncologist at Mount Sinai Hospital. He also is a researcher in the Samuel Lunenfeld Research Institute, and his clinical practice specializes in patients with hereditary cancer syndromes. He does surveillance for them, and he also does surgical management of their colorectal cancer. His research lab investigates the genetic determinants of colorectal cancer risk, prognosis, and response to chemotherapy. So let me introduce Dr. Greif for your next talk, which is going to be on lower GI screening and polyp management following surgery. Thank you, Dr. Greif.
Hi, I'm hoping you can you see my screen?
Yes, we can.
Okay, unfortunately, I don't know, I have my camera on, so I apologize that there's something wonky going on with the video, because I don't seem to see my face, which is probably good for many of you. The slides are probably better. So I want to thank Melissa and Tom and Kara and the organizers for inviting me to talk, and I very much enjoyed the talks before, and I look forward to the rest of the evening. Tonight I'm going to talk about lower GI screening and polyp management after polyposis surgery. So I know that it would be really nice if the journey was over after you had prophylactic or treatment surgery, but that's unfortunately not generally the case, as I'm going to talk about now. Sorry, I will. So I do have a disclosure, which is I'm a co-investigator in a clinical trial that was published, and this is actually a chemo prevention trial in FAP, and I will be talking about it towards the end of the talk. And I actually want to acknowledge and thank the patients who participated in that. And I think it actually adds a bit of an exciting part of the talk, because this was recently published and has some things to think about in terms of polyp management in FAP. In terms of the surgical treatments for FAP, this is a colon with typical FAP and hundreds, if not thousands, of polyps. And in those cases, essentially, you need an operation where the entire colon and rectum is removed. And after your total proctocolectomy, so after the entire colon and rectum is removed, most individuals are reconstructed with a pelvic pouch or an ileal pouch anal anastomosis, or IPAA. They're all the same thing. In some people, either due to choice, due to rectal cancer, or due to poor sphincter function, they may require a permanent ileostomy. In some individuals who have fewer polyps, and particularly polyps that are not abundant in their rectum, they can have an operation where their colon is removed and the rectum is retained. And so you have what's called an ileorectal anastomosis or an IRA. That would be common in people with FAP where it's attenuated, and in a syndrome like mute-YH or MYH associated polyposis, where there are fewer polyps and you can remove the ones that are in the rectum because there aren't too many, as opposed to in this picture where you see that there's many. So following your surgery, what do we do? Well, we do recommend screening, and I'm going to later on in the presentation give you the reasons behind that. But essentially, if you've had your whole colon out and you have a pouch, or you've had your colon out and you have an ileorectal anastomosis, you should have what is left of your lower GI tract screened every 1 to 2 years, with the goal of removing all the polyps that are greater than 5 millimeters. And here I'm going to show just a bit of a picture. It's a bit of a show and tell. I think it's interesting for anybody, and particularly those who have a pouch, to see the parts of the pouch. Like you may not know, but there's sort of, various things. So when you go in and you go past the pouch, the area just above the pouch, the terminal ileum, the end of the small bowel, that's the afferent limb. So that's what we're seeing here, and that's number 1. When most of the pouches that have been created in the past 2 decades, but not all, are of a J configuration. So what that means is that the bowel is looped over and the wall is opened up in between to create the pouch, but it leaves a blind end where the end used to be of the small bowel. And that's called the efferent limb. And here's looking up at the efferent limb. And then you can look up at the pouch itself, and the following 2 pictures are pictures where people are looking into the pouch. And here you can see both the afferent, and this is probably the afferent limb, and this is probably the efferent limb. And similarly here, this probably goes up into the terminal ileum. It's the afferent limb, and this is the end of the pouch, or the efferent limb. When you're pulling the pouch out and you're just above the anus or just inside the anal canal, this is where the pouch attaches. And below it is the rectal cuff and the anal transition zone. So this area really low down here. And then finally, if you flip the scope around, you can look and see this same area, but you're looking downwards at it. So you're looking from the top, and here's the scope looking downwards. And what you can see is just that little rectal cuff, anal transition zone, and then the pouch above it. So those are the parts of your pouch. Well, why do we recommend such frequent screening for people who've undergone the surgery to remove their entire colon and rectum, or those who've had fewer polyps and just have the rectum there? So first, I'm going to talk about the situation where you've had your entire colon and rectum out and a pouch reconstruction. It turns out that actually polyps are extremely common in the pouch after the surgery. And at 10 years, anywhere between 30 and 60% of patients will have had a pouch detected in the pouch. Most of those polyps, but not all, about 3/4 of them, arise in this area down here, the rectal cuff and anal transition zone. And for a long time, it's been a big debate in terms of, can we lower that risk, and does it make a difference? Well, in fact, there is part of your operation where you're having your colon and rectum taken out and a pouch created, where we can do another part from down below where we strip the lining of the rectal cuff and the anal transition zone, and that's called a mucosectomy. And in fact, when we compare patients who've had mucosectomies with those who haven't had this area stripped in order to make their pouch, in fact, it reduces the likelihood of polyps by about 50%. So it's like 15 to 30% instead of this, the double number here, which seems like a great idea. Why wouldn't we do that? Well, in fact, like most things in life, you pay a price for it. So what happens is if you do that, it increases the risk of poor pouch function. It also increases the risk of complications in the pouch, and ultimately it increases the risk of the pouch failing and needing to be removed and having an endoileostomy. So even though it decreases polyp number because of these shortcomings of the mucosectomy, unless it's required for very distal polyps, we don't routinely recommend it. What happens with the polyps? Well, most polyps can be removed endoscopically, so that's good news. Occasionally, polyps do require surgery through the anus. That's about 10% of the polyps that we encounter. And occasionally, just we can't eradicate them. They're too confluent, they're too aggressive, and about 3% of people would have to have their pouch removed because of polyps, despite having a pouch. Fortunately, though, if people have regular surveillance, cancer is actually rare. It's in the order of 1 to 2% over a lifetime with a pouch. And also, in helping make this decision about mucosectomy, it's not prevented by mucosectomy. So while mucosectomy decreases the number of polyps by about 50%, it has not been shown to decrease the incidence of cancer in the pouch. When you do have a cancer in the pouch, in these unfortunate few percent of people, that requires that the pouch be removed, an ileostomy made, and like other cancers, it frequently requires chemotherapy and/or radiotherapy. Well, let's talk about the other option. In individuals who may not have as fluid polyposis or who have MYH-associated polyposis, they may not have so many polyps in their rectum. And as I alluded to in a few slides ago, they can have their colon out but retain their rectum. So why would we do that? Well, if you compare an ileorectal anastomosis and a pouch, there's a pouch operation almost always requires a temporary ileostomy, whereas that's not required for an ileorectal anastomosis. It's a less technically challenging operation that has fewer complications. That's better. Overall, while people, especially with FAP, have excellent bowel function for a pelvic pouch, if you take a population of people with an ileorectal anastomosis and compare those same as a population of people who have a pouch, there's going to be better bowel function in those with an ileorectal anastomosis. And finally, low pelvic surgery in females does contribute to female infertility. And so when you have the rectum still there, we avoid that surgery and there's better female fertility. So who do we choose for, or who can we recommend get a subtotal colectomy in ileorectal anastomosis? Usually people have 20 or fewer polyps. Usually there's no advanced changes, so there's no high-grade dysplasia or cancer. We have to be able to remove essentially all the polyps, but certainly all the polyps that are 5 millimeters or more that are in the rectum to contemplate it. And also, interestingly enough, there's a specific in terms of the type of mutation that you have in the APC gene that really tells us a lot. So here's a picture of the APC gene, and the red, gray, and green show different zones of the gene where people can get mutations. And this area here, right in the middle of the gene, that leads to severe polyposis. And we know from studies done in the past, if you have an ileorectal anastomosis and you have those types of mutations, you will develop rectal cancer after an ileorectal anastomosis 7% of the time at a very young age, by a mean age of 35. In contrast, if your mutations are in the gray part, the intermediate zone, you will still develop cancer about 8% of the time, but you can see here, it's about 15 years older on average. So that's a more intermediate type. If your mutation is in these parts of the gene, the green parts, that leads to what's called attenuated FAP. And in that case, If you have an ileorectal anastomosis because your presentation didn't have very many polyps, there's only a less than 2% chance of developing rectal cancer, and it's generally not diagnosed until later in age compared to the other circumstances. So these are the reasons why we would be able to offer that as the polyp lowering operation. But what happens to those people in terms of their polyps? Well, it really depends on what your mutation is. So after an IRA, if you have attenuated polyposis due to an APC germline mutation, you will develop polyps. So here, yet again, just like in the pouch data that I showed you before, really a justification for why that endoscopy is needed every 1 to 2 years. In the case of MYH or mut-YH associated polyposis or MAP, it's extremely variable. And we don't understand the reason why some people will develop polyps, similar to people with attenuated FAP, and why some people don't. So because of that, generally speaking, you still have to have your rectum closely monitored. Fortunately, again, like after the situation with a pouch, if you have your rectum in, but you're regularly surveyed, most polyps can be removed endoscopically. If you have severe rectal polyposis, you may need the rectum taken out, and about 2/3 of those people can then be reconstructed with a pouch. So they went from a subtotal colectomy IRA to a completion proctectomy and a pouch. Unfortunately, some of those people, due to the nature of their polyps, will require that things be taken out and have a permanent ileostomy. Although generally speaking, we're now talking about an older age by the time that that's occurring. For appropriately selected individuals with attenuated polyposis undergoing regular surveillance, rectal cancer is very uncommon. It only occurs in 1 to 2% of people who are being screened after ileorectal anastomosis. Depending on the size and the location, it still may be possible to remove the remaining rectum and form a pouch. Otherwise, it would require that the entire remaining rectum be removed and an endoileostomy performed. And similar to other rectal cancers, chemotherapy and/or radiation treatment may be needed. So in switching gears from monitoring and taking care of polyps by endoscopic and surgical procedures, can we prevent these polyps? Well, there's been a number of studies that have looked into this. And the first thing I do want to point out is that there is no drug that is FDA approved for FAP chemoprevention. So by that, you can understand that there's no miracle drug in terms of what to do. Many studies have looked at this drug, Sulindac. Some of you may be on it. Sulindac is a non-steroidal anti-inflammatory, so it's an aspirin type drug, or what's called a non-selective COX inhibitor. And the clinical trials where people on Sulindac have been compared to people on placebo, it does significantly reduce polyp number and polyp size. And that was seen in 3 out of 4 randomized controlled trials. However, Sulindac can cause gastritis and other GI concerns, and it can also cause kidney problems. So, you know, there's a trade-off in terms of being on it for a long time. And certainly in terms of the gastritis, if you're on Sulindac, you should be on something to lower stomach acid. So a group of drugs called PPIs or proton pump inhibitors to prevent ulcers. Another drug that's been looked at a lot is celecoxib, which unlike aspirin and Sulindac and naproxen and those types of drugs, is a selective COX-2 inhibitor. So it's inhibiting half of the pathway that these non-selective inhibitors do. Similar to Sulindac, celecoxib does reduce polyp number and polyp size in most, but not all, randomized controlled trials that were done in FAP looking at polyp reduction. However, unlike Sulindac, which has real side effects, but generally speaking, not fatal side effects, celecoxib can have cardiovascular side effects, which include heart attack and stroke, which really makes it not ideal for long-term use, which is what generally you would need in terms of a chemo prevention agent. The other thing that's important to understand is that Sulindac, or perhaps in the future other medications, can be used to help with chemo prevention, but they aren't a substitute for screening, and they're not a substitute for surgery. So if you can't go on it and then not be screened, and you can't unfortunately believe that your polyps are going to regress in a way that's going to avoid surgery. The final thing I want to talk about this evening is something that was published less than a year ago in the New England Journal, and that was a clinical trial in patients with FAP, which the Familial GI Cancer Registry participated, and a number of you may have participated. And again, I thank you for that involvement, where it looked at a drug called eflornithine and Sulindac, and the non-steroidal, as prevention for progression in familial adenomatous polyposis. Now, eflornithine, or DFMO, is what's called an ornithine decarboxylase inhibitor. It's just the pathway that it inhibits from a biochemical standpoint. What's interesting about it is it's an existing drug because it's actually an anti-parasite medication that's used in sleeping sickness. The study itself, which was conducted in multiple centers in North America and Europe, involved 171 patients with FAP who were randomized to treatment, which was considered to be both drugs, so the eflornithine and Sulindac, or control. So there's 3 arms in this, and one control arm is the eflornithine alone, and the other control arm is Sulindac alone. So everybody received a type of treatment. The patients enrolled, there were patients who had their entire colons and rectums in, but had known FAP. There were patients who'd had their entire colons and rectums out and were and had a pouch. There were patients who'd had their colons out and had just their rectum in with an ileorectal anastomosis. And there were a small number of patients who'd had their whole colon and rectum taken out and had endoleostomies. And you may wonder, well, why would that be? And it's because actually the aim of the trial was to prevent both colorectal and duodenal polyps. And the way it worked was the medications were given to individuals over the course of 2 to 4 years, and the patients were watched over the 2 to 4 years. And in fact, this study is a negative trial. And what I mean by that is it didn't prevent polyp progression. And that has to do with the way the polyps were defined. So before the study, it was defined as looking at whether or not you needed treatment for either duodenal or colon or colorectal polyps. And what we saw after the trial was done, that duodenal polyps, in fact, were not affected by this combination of medications. So the trial itself was negative. However, if you look at just the patients who were in a situation to have things monitored in terms of either their pouch and the cuff and ATZ, or had an ileorectal anastomosis, what you can see here is if you were on combination therapy and you had your whole colon in over the 2 to 4 years, no patients went on to need colectomies. However, somewhere between 17 and 31% did go on to need colectomies if they were on either DFMO alone or Sulindac alone. So that seems like it helped. And similarly, the trend was seen in patients who had already had surgery. So when you look at patients who'd had a pouch or had an ileorectal anastomosis and assess them as to whether or not they developed a polyp that was greater than 1 centimeter over that 2 to 4 years, or if they went on and needed a surgical resection in that 2 to 4 years, the patients on these drugs did not. However, the patients on either Sulindac alone or a eflornithine alone, somewhere between 8 and 25% of them did go on to have either a large polyp or actually require formal resection. So either their rectum removed or their pouch removed. So there appears to be a reduction in colorectal polyp progression, but I would caution you, these are very small numbers, as you can see. And so, this remains to be seen. This was just published in September of last year, and more work is ongoing to see if this is appropriate or not. There was no difference in overall or serious treatment-related adverse events. So all these medications do have side effects, but what this means is that the combination of the two didn't have worse side effects than either drug alone. So in terms of just summarizing what I've talked about tonight, lower endoscopic screening of your remaining lower GI tract is recommended every 1 to 2 years after either pouch surgery or ileorectal anastomosis in FAP, attenuated FAP, or MYH-associated polyposis. It is quite common to develop polyps, particularly in the rectal cuff and anal transition zone after a pouch. This can be reduced by about 50% with a procedure at the time of your pouch called a mucosectomy. However, it also, that same procedure leads to greater pouch dysfunction and failure, and ultimately doesn't change the likelihood of developing cancer. So because of that, we only perform mucosectomy where it's necessary, and that's generally where there are very low polyps that can't be removed without it. And we don't routinely perform this when we're doing a total proctocolectomy.
Bring it here. Come here.
Following ileorectal anastomosis for attenuated polyposis, rectal polyps are common, but far more variable in MYH-associated polyposis. Most individuals with a pelvic pouch or an ileorectal anastomosis who develop polyps can be managed endoscopically. So most of the polyps can be taken out with the scope. However, about 10% of the time, those polyps will require a transanal procedure. And in about 3% of patients with pouches, it will require the pouch be taken out for polyps. Or if somebody has an ileorectal anastomosis, generally at an older age, about 5 to 10% of people will need their rectum taken out and then a pouch created, or potentially have things taken out with an endoileostomy. Fortunately, in all scenarios with regular screening, cancer is rare and really only occurs in 1 to 2% of individuals. Sulindac can be used as a chemo prevention, maybe soon eflornithine and Sulindac. And with Sulindac, because of the gastritis, you should be on a proton pump inhibitor. And I want to thank you for your attention.
Thank you so much for your amazing talk. It was great. We have a whole bunch of questions that came in for you. One of them was actually asking about the mucosectomy and when that is indicated, but I think you actually just answered that. So I'm going to ask this question. Is there a difference in developing cancer in people who have a pouch versus an ileorectal anastomosis?
So the answer in general is no, and that's in the modern era. So that's taking into account that the people we're selecting for ileorectal anastomoses are appropriately selected. So they have fewer than 20 polyps. None of the polyps are greater than 3 centimeters. None of them have high-grade dysplasia or cancer. All polyps greater than 5 millimeters can be removed, and that they don't have intermediate or florid polyposis mutations in the APC gene. So that's the current standard. But if you think about it, once upon a time, there was no reconstruction. There was no pouch. Prior to the 80s, the early 80s, there was no pelvic pouch. And there's been FAP recognized for far longer than that. So there's a long history leading into that, and also in the beginning of pouches when they weren't so readily available, where patients' preference would be to have an ileorectal anastomosis, but they wouldn't be considered proper patients for that operation these days. But not unexpectedly, those patients frequently developed rectal cancer.
And what about a permanent ileostomy? Is there a lower risk for cancer if you have a permanent ileostomy?
Yes, so essentially the risk of colorectal cancer is essentially zero with a permanent ileostomy.
We had some questions about screening during COVID and how COVID is delaying some of the screening, especially, I know your talk is on the lower GI, but I know you know about the upper GI. So they're saying, what do they do about the fact that COVID's delaying gastrectomies or side viewing scopes? Some people, it's been 24 months since their last one and they're overdue. So any comments about that?
Yeah, so I think it's an excellent and a stressful question. And if I had a good answer to the question, I guess I would be the premier of the province or the prime minister of the country, because it is definitely a big problem. What I would say is you should contact your individual endoscopists and see what the status is. There is definitely a backlog in terms of all interventional procedures, whether they're surgery or angioplasty or colonoscopies or duodenoscopies. But there are many centers that are still running and have run pretty close to at full tilt during COVID, with some brief periods where they had to scale back. But it's an excellent and a stressful question. I think the good news to know is that very rarely are these things rapidly growing. And, it tends to be that most things in medicine for screening and most things in treatment, in fact, that's a conservative approach. Like we're trying to take almost the worst case scenario. So there generally is a bit of leeway there.
And maybe this one last question, is there anything you can do as far as diet or lifestyle or even gene therapy to reduce your risk of developing these adenomas from the start?
Right. So, I mean, I think still the best information is that in terms of chemo prevention with like Sulindac. And what we know is in something like FAP, it can make a difference, but ultimately it's not preventing surgery because unfortunately the genetics are stronger than the lifestyle and nutritional things. There are other things that probably help. Aspirin, in a general sense, similar to Sulindac, has been shown to decrease polyps. There have been a lot of trials in terms of vitamin D and calcium and high fiber, but none of those things have specifically been shown. I mostly tell people that our mothers know best. So, what our mothers told us to do in a non-specific way is really helpful for lifestyle in general. So you should drink in moderation, you shouldn't smoke, you should eat the right foods, you should exercise, but there's no specific answer here.
Okay, thank you so much.
Well, thank you.
Yes, I second that. Thank you very much, Rob, and also to our prior two panelists. It's been really educational so far for us and hopefully for the audience as well. So thank you for joining us. I would now like to introduce our patient speaker for this evening. We have Linda joining us. Linda has been part of the Familial GI Cancer Registry for nearly 20 years, from what I could calculate. She was diagnosed with FAP many years ago, and no doubt has volumes of experience and wisdom to share with us. So please join me in welcoming Linda, who has bravely stepped up to share her story with us this evening. So Linda, I'll pass it over to you.
Thank you. Hello, everyone. I hope you can all hear me. My name is Linda, and I have familial adenomatous polyposis. Thank you to Dr. Cohen, the Center for Digestive Diseases, Familial Gastrointestinal Cancer Registry, and the doctors, nurses, and staff at Mount Sinai Hospital for their great dedication, care, and support of persons like myself with this condition. I honestly believe without them, I would not be sitting here today. I was diagnosed with FAP approximately 34 years ago at 16 years of age. I sat beside my parents at a gastroenterologist's office in North York, waiting for the test results of a scope after blood was found in my stool. I anticipated that the specialist would tell me that all the tests were fine, that I must have overreacted or misunderstood my symptoms, expecting us to be ushered out the door. Then I heard the words a 16-year-old never imagines to hear and never really understands. I have hundreds of precancerous polyps in my large intestine. I have a genetic disease that will need major surgery right now, and I will need ongoing treatment for the rest of my life. 2 months later, I had a partial colectomy at St. Joseph's Hospital. I was probably the youngest patient on the floor at the time. I stayed overnight prior to surgery and was shown a video on what the procedure would entail. Even with all the support from the doctors and nurses, it was overwhelming. I think that is when I experienced a panic attack for the very first time. I woke up after surgery remembering how cold I felt, surrounded by tubes, beeping noises, and lots of strangers. As a teenager, I wasn't prepared for post-surgical pain and how isolated I would feel away from home. That was the beginning of a journey beyond innocence through times of anxiety, depression, and pain towards growth, resilience, faith, and hope. It's relatively easy to say that now, but at the time I was struggling for a sense of control. Between the biannual scopes, biopsies, thinking about future surgeries, I needed to find ways to cope. So I opened up to my friends about my condition. I joined group therapy and tried my very best to be honest, yet positive, and even self-deprecating about it. I found that what helped me most was that I wasn't bottling it all up. At 21 years of age, I was told that I would need 2 more surgeries as the polyps had gotten too numerous in the remaining colon. The surgeon described it as an internal J-pouch procedure. I would have a temporary ostomy bag while the small intestine healed. Then they would remove the ostomy 3 months later. Now, having an ostomy bag at any age, of course, is an adjustment. But at 21, it was intense. Emotions, friendships, dating, and life in general became very challenging. All my friends were going out, meeting new people, enjoying life, and I just wanted to feel like everyone else, normal, if that makes sense. I had difficulty with the ostomy and keeping the bag attached. I would try to go out, the bag would detach and leak, and I would return home embarrassed. Most days, I would stay in my room just feeling sorry for myself. Luckily, there was a post-operative team that followed up with me, and I was visited by a fantastic ostomy nurse to help me out at home. She was so knowledgeable about the supplies, and she even had an ostomy herself. So she was speaking from personal experience. I was just relieved to have someone to talk to who understood what I was going through. Even though I did have a lot of great help, I continued to struggle. I just did my best to get by and get on with it. I reminded myself that the stoma was only temporary, and as soon as I get past the next surgery, I could put this experience behind me and move on. I got into individualized therapy, and I worked even harder to be positive and develop new friendships. During hospital stays, I would go out of my way to connect with people, doctors, nurses, patients, anyone around me, who throughout my experience have all been wonderful. I made it my mission to become the hospital wing's social butterfly, and it made those days a lot easier. In 2002, I began having annual scopes at Mount Sinai Hospital. That is where I was introduced to the Familial Gastrointestinal Cancer Registry. I was offered genetic testing for myself and my parents. The test results revealed my gene mutation and that I was the only one in my family with the affected gene. I was also informed that if I had children, they would have a 50% chance of having the disease as well. The information, availability of team members, and genetic counseling that they provided was so integral to my learning to live with this condition. For someone that was feeling isolated and anxious about it all, that meant everything. I knew then that I would continue to have feature scopes and surgeries. And over time, I gradually came to think of hospitals as my home away from home. Sounds weird, I know, but it got me through. I also developed a strong faith and belief in the simplicity of being grateful, even when I was given news I didn't want to hear. I didn't realize then how much that would help shape the person I am today. In 2005, during a routine scope, they had identified a periampullary adenoma. It's a large polyp very close to the pancreas. I was sent to St. Michael's Hospital to have it removed. After the procedure, they kept me overnight for observation. In the middle of the night, I experienced probably one of the most intense pains I can recall. The following morning, a scan had concluded that I developed acute pancreatitis, a rare side effect from the procedure. The doctor was impressed that I had handled the pain so well overnight with only minimal pain medication. That's me, crazy anxious, but a leader in pain management. That should be a reminder to all of you. Good drugs make happy patients. Don't forget to ask for the good stuff. I was hospitalized for a week, and the diagnosis of something new, and of course the pain, caught me off guard. I learned the hard way that strong physical pain can affect your mental health too. I started to feel depressed in the hospital. I didn't understand why at the time. All I knew was I needed some help. I was offered that help by way of a hospital chaplain who talked with me during my hospital stay. When I was discharged, she helped put me in touch with a great therapist to follow me through my recovery at home. I was never ashamed or afraid to ask for help. I just knew I needed to talk about it with someone. I could handle physical pain because I always assumed that it would pass. Mental trauma was a little more persistent and unpredictable. In 2008, at Mount Sinai Hospital, I was diagnosed with rectal cancer. As my surgeon was describing the diagnosis and the possible treatment outcomes, I was in shock, of course, and I couldn't hear anything past the word cancer. It's amazing how your brain works over time to protect you, even turning off your hearing. During the following exploratory procedure, she was able to excise the lesion without the need for future radiation. It was such a relief and a blessing. In 2009, after getting married, my husband and I had the difficult conversation about having a child and the possibility that they could have the FAP gene. As my husband also was a type 1 diabetic, we were informed that there was also a possibility, very rarely, that he or she could have diabetes as well. What if they had FAP? What if they had diabetes? What if they had both? These were all questions we had to sort through and answer. Our answer was always that we wanted to have a child, and when the time came, we would get them tested. We ended up going through fertility treatment as I was 38, and my past surgeries had caused scar tissue to block the fallopian tubes. With the help of a great fertility doctor and one great embryo, I was pregnant. I gave birth to my daughter in 2011. 9 months later, just when our daughter was starting to sleep through the night, I was again diagnosed with rectal cancer. This time I would need major surgery that would involve 2 very large incisions, one along the abdominal pelvic area and the other behind. It would involve removing what was left of the rectum and placement of a permanent ileostomy. Try explaining that one to friends. I was also very obese and was told that this could cause post-operative complications. Of course, I was devastated. The diagnosis came less than a week before our first Christmas with our baby girl. It was bittersweet, trying to be joyful about our daughter and grateful that the cancer had not metastasized, but worried about such a huge surgery and how to manage it all with an infant daughter. I had surgery 2 weeks after initial diagnosis. While recovering in hospital, I got updates about how our daughter was doing, and my husband was awesome in finding ways to make me laugh and always stay calm and positive. Within just 5 days, I was sent home with clear instructions about no lifting for 3 months. It was hard being away from my daughter and then coming home and not being able to hold her. I think it affected her too. She became hesitant to come to me. As much as I promised I wouldn't, when I was feeling stronger, I couldn't help but pick her up. As I recovered at home, I got reacquainted with having an ileostomy again. Everything felt different. It's impossible to explain how foreign my body felt to me. I also had ongoing pain coming from all over the place. I wasn't sure if it was just something new from the recovery pain, something that I had to get used to, or if something was wrong. So much had been done to that area that there's no roadmap down there, you know? It's all just a big lumpy sack of chopped up giblets. I did my best to acclimate to this new normal of post-surgery life. I experienced chronic pain, difficulty urinating, menstrual issues, all related to scar tissue adhering to neighboring organs. You know, the fun stuff. But with a supportive family unit, a healthy child to focus on, and a return to full-time work, I settled into it really well, I think. Then came the news that I developed a peristomal hernia due to my obesity at the time of my cancer surgery. In 2017, I went on a liquid diet to lose 40 pounds and then had laparoscopic surgery to repair the hernia. Less than a year later, I gained some of that weight back and the hernia reappeared. I returned to Mount Sinai to have a resite of my stoma and a second hernia repair. I was in hospital for 10 days, suffering partial bowel blockages. I was put on a post-ileostomy diet that severely limited my food intake to help with the passing of food. I couldn't digest most vegetables and fruits, even months after surgery. So I turned to unhealthy foods, and again, my weight struggles continued. In 2019, and what would be my 10th major surgery, I had my third hernia repair. I've had a few setbacks since then, but every surgery brings its own increased set of risks and complications. Especially as you get older, when you're not in great shape to begin with, that's just how it goes. And you just have to find a way to deal with it. My friends and I joke about it to this day. Some call me the medical miracle, but I like to call myself the surgery queen. And after continued post-operative complications that I continue to struggle with today, and after a lot of thought and consideration, I made the difficult decision to retire at the end of last year at the age of 49. This year, my daughter turns 10. She knows a lot about my condition and living with an ileostomy. I don't try to hide it from her. That wouldn't be fair. I don't want her to be afraid. And because I had many surgeries since her birth, and at some point one or more in my future, my husband and I have done our best to show her that hospital visits are healthy and can be positive. Anytime any one of us had to go to the hospital, my husband will make a habit of taking her to the gift shop and having her pick out a few presents for herself. He wouldn't stop there. He would buy her ice cream, take her out to lunch. Mandarin was her favorite. You name it. It became a little ritual between the two of them. I think he remembers it from when he was a young kid with type 1 diabetes, having to visit the hospital for his needles, and how that was something he always looked forward to. It is one of the ways we can pass on our messages of hope and faith to her. This summer, we are preparing to get her tested for FAP. Am I scared? Oh, yes. How do you prepare your daughter for something you were never prepared for? How do you toughen up your kid for the challenges they will face? I'm still navigating that as we speak. But I know that if anyone can give her an accurate personal perspective, that would be me. I just hope I can instill in her the strength and resilience I found in myself. My husband, for his part, has such a positive attitude about it all. God bless him. This diagnosis, this whole experience is so humbling. It makes you so grateful to be alive one moment and then frustrated about the challenges you face in the next moment. However, those challenges show how resilient we all are. That resilience is fortified by the support from family and friends and the kindness of everyone at the hospitals and clinics that provided care. I know with the pandemic, the whole world is now reflecting on the amazing work that happens there. I have had the privilege of witnessing it for decades. If I can impart some final words, be kind to yourself and listen to your body. Find simple little things to do that bring you joy. If you feel isolated and alone at any time, remember that there are a lot of people out there that will understand. Most importantly, reach out to someone around you and share your journey. Thank you.
Thank you so much, Linda, for sharing with us. It was touching to hear all of your experiences and stories, and therapeutic for all of us. As you mentioned, it would be for you. So thank you so much. That was really from the heart. And I had a couple of just questions for you based on some of the things that you said and to elaborate on. One was, what advice would you give to people with young kids to best prepare for the surgery? So you talked about taking your daughter with you and talking it through, but personally from your side, having been through it so many times, what have you learned from that in terms of just preparing your family, preparing your household, and for what things are like after surgery?
Yeah, it's apart from the making the hospitals a positive thing, I wanted her to get comfortable sharing her feelings. So when I found that if she had any struggles with talking to me about anything, I would have her see a therapist as well. I just thought that was easier. Sometimes kids find it easier to speak with other people other than their parents, and share their emotions. Really more knowing where they're at, instead of trying to sort of force the information on them, kind of have them come to you with it. And I never really, I with my ileostomy, it was always open. I never hid myself. I never hid the ileostomy from her, and I just called it my boo boo. But no, I just wanted her to know that it's normal. It's okay. It's just how mommy is. And I think that when the time comes, I know I'll definitely be there for her to sort of explain things to her. But yeah, every kid is different. Some kids want a lot of information, some kids don't. And, there's no right or right. I know they say this all the time, but there really isn't any right or wrong way. Your kid more than anybody else does. So, if they're a kid who needs a lot of information, then give it to them. And if you think they can deal with little information, then do that too.
Sure, you're right. It's different in every situation. But those are some great insightful words. Thank you. We have a question from the audience asking if it was challenging for you with respect to things like looking for jobs, commuting to work with a pouch, some of the more practical things, and just going through your day-to-day life and work, and trying to figure out what foods you can eat, traveling, just things like that. If you have any tips or strategies that you could share.
Yeah, I purposely left it out of my speech because work is its own environment. And it brings its own challenges. I love working. I miss working so much. I miss my friends there. And it was challenging. I did have some leakage accidents there, of course, and it was important to have people around you that you were comfortable enough to tell them what was going on, because there's sometimes you can't hide it. You just can't. I would just say, some people can do well without sharing it with anybody. But in my experience, I needed that support. I needed people to know about it. So I did share that at the last few works that I was at. I also think that having as much as you can, of course, a positive, friendly, light-hearted environment at work. Always come prepared for at least a couple of accidents. Always pack a bag with everything you need times two. I've had to run home a couple of times. Yeah, always pack a bag. Traveling, traveling is, it was okay. It was okay. And it it just depends on how you're feeling with your ileostomy. If you're in a good place with it, sometimes we have setbacks with how we're going. So it just depends. And of course, what you eat is really important. It does, what you put in, it really does show if the output's going to be fast and loose, or it's going to, so that's really important. If you want to have an ileostomy that's not flowing so quickly, that so you don't have to go to the bathroom all the time, peanut butter, peanut butter, peanut butter.
That seems to be a theme tonight.
Oh, right. Yeah, that's true. Yeah, peanut butter. But yeah, so that's what I would say.
Thank you for that. We have a couple of comments I just wanted to share with you as well from some of the members of the audience saying that you're such a strong, beautiful person. Thank you for sharing. Thank you for sharing your story. Good luck with everything and with your daughter. So some nice sentiments, and I'm sure that the audience as well as us panelists really appreciated hearing your story. And thank you from all of us for taking the time tonight and for putting all of that together and sharing your words of wisdom. So thank you very much.
Thank you, Kara.
I think on that note, we'll call on Dr. Cohen to say a few closing words. As well, I believe there was a question we wanted to go back to from Dr. Greif's talk that Melissa, I think you were going to ask or address. Thanks.
Yeah, so good, you're still here, Dr. Greif. So we did have a question about cock pouches and when that's appropriate and what that is exactly. We just wondered if you could address that. And I also wanted to say to Linda, that was amazing and such practical information you gave. So thank you so much. So Dr. Greif, if you have any comments about that.
Sure. So first, I also would like to acknowledge Linda's talk. It was really powerful, and it's so important as a physician. I mean, obviously we hear from patients all the time, but in this type of format, it's really incredible to hear about a patient's journey. So I really thank you for sharing that with everybody. So cock pouches, for those people who are wondering what that is, it's an ileostomy that's a continent ileostomy. So instead of wearing an appliance, it sits flush with the skin. You usually just have to put a gauze over it, and a few times a day, you put a tube into it to actually drain it. So it is a very specialized operation. It sort of had its heyday for a short period of time because the technique was developed before the pelvic pouch was developed. So there was sort of this brief era where people couldn't have pelvic pouches, and then when they could, generally speaking, that would be the restorative. They would want a restorative operation rather than a continent stoma. It's really a subspecialized operation. So there are two surgeons at Mount Sinai who still perform cock pouches in very, very selected individuals. It is worth understanding that it's a complicated operation because the likelihood that you will have technical problems with a cock pouch is quite high. The likelihood that you will need future surgery is quite high. And the amount of bowel that gets lost every time that it's revised is significant. So, if you need a revision or you need it excised, you're going to have less small bowel, which means the ileostomy is going to put out more fluid, thinner fluid. It could be more of a challenge in terms of dehydration, things like that. So there are still cock pouches for very selected individuals, but it is a bit of a vanishing niche that really there's only two of the 5 colorectal surgeons still working at Mount Sinai do them selectively. And as far as I know, that's it in all of Canada.
Thank you for addressing that, Rob. I think that clears it up. And Zane, if you are on.
Yes, I'm right here. I'm right here, listening intently to all of these great presentations. I do hope that everyone in the audience, I may be in the audience now, I was having a little trouble beforehand logging in, has learned something from these talks. They were really very well constructed. And from the first talk, my impression was, how far have we really come in the technology of pre-implantation of genetic testing? I mean, it is pretty amazing, pretty fantastic. And that wasn't available. I don't know exactly when it became available, but it's a fairly recent innovation, which can be so helpful to people. We're lucky to be able to have the expertise to do that. Abba's presentation, I thought, was really well constructed and extremely good, very informative. And the message that she kept repeating was, I think, the right one, that if you're asymptomatic, then don't worry about it. Surgery is a big risk factor for the development of desmoids. It's not the only risk factor. So I don't think people have to go home, and I would just reiterate, and worried about getting CT scans done and worrying about having a desmoid when they're completely asymptomatic. I absolutely agree with that. And Rob gave a masterful demonstration pictorially as well on what you have to understand about surgery and polyposis, as well as surveillance. Very, very important. And also stress the fact that cancers are extremely rare in these situations. And Linda, it's great to see you. It is very difficult to open up like that. I was trying to think, maybe you could answer this as well, since we're chatting a bit, that what's more difficult, to stand up in front of 100 people in an auditorium or to do this on a Zoom call? I'd be interested in your answer to that, because I have my own ideas about which one is more difficult, but I'd like to hear from you in just a minute as I wrap up. But I also want the audience to understand and know that we have a lot of expertise in these areas. And we are there to not only support people, and people will call on us frequently to help support them, but I know, Linda, that you will have the intestinal fortitude, because I think it's a good word, intestinal fortitude, or 2 words during these talks tonight. You'll have the intestinal fortitude to address this problem with your daughter, and even get closer to her when you do that. Because when a family has a crisis or a difficult problem and they can talk it out, then that does bring families closer together. So I think, looking on the bright side of things, you will do it. You will be happy that you did it, with all the knowledge that you have to give her in a positive way, and we are there to help. And what I would say as well, as far as our counselors and surgeons and everyone associated with our center is concerned, we really do listen to our patients, because the patients bring the disease issues and problems to us for us to try to solve and to help. And we include patients both on the inherited cancer side as well as the inflammatory bowel disease side, which we also do. Bring them into the conversation to help us with a path forward when we're looking at things to do and important issues that we have to address. So I'm really proud of all of the people in our group because they all have those same values and they all relate to patients extremely well. And with that, I'm not forgetting, I'm going to ask you to comment on that, my question, but I just want to thank everyone again, particularly our counselors, for handling this tonight extremely well, moderating it, asking the questions, and thank our presenters. It's been a great night. It's always a great night when we have these educational forums, and this is the third one. Of course, there will be a fourth one. I don't know exactly when, but I'm really hopeful that we'll do this in person. So the next person the next patient that we get as our speaker, we'll have to address people in an in-person setting as opposed to a Zoom setting. So maybe you could just finish off, and maybe our counselors have a last word as well, but maybe you could just finish off and tell us your experience about being on a Zoom call doing this as opposed to thinking about doing it in person.
I think it was easier on a Zoom call because I'm not staring off into all of the audience, and I saw how many participants there were, and I thought, okay, I'm just going to focus on the screen and say my bit. I get a little bit nervous with a huge crowd, but so it was a little bit easier. Yeah.
Right. Okay. I had the same impression. I would have the same impression also. Okay, back to you, Kara.
All right. I think that wraps it up really well. Thank you once again, Linda, Diane, Dr. Gupta, Dr. Greif, and all of my colleagues for helping out tonight, Tom, Melissa, Dr. Cohen, and Hardin in the background. We really appreciate everyone taking the time to join us tonight. And as Dr. Cohen said, hopefully we can meet again in person in a couple of years' time. So take care, everyone. I think that ends our session for tonight.
Bye. Thank you again to everyone. And thank you, Hardin. I didn't mention you, but you are a very important person. Thanks again.
Thank you,
Bye.
everyone.
Bye, everyone.
Good night. Good night.